be speaking on the topic of the epithelium and how it impacts the refractive outcomes, because that's kind of the new kid on the block. So the normal corneal epithelium, we know, consists of 4 to 6 layers, and how we see it in clinical practice basically is we have multiple OCT devices. We have the Cassia, we have the Anterior, we have the MS39, and all of these, with a simple click with the OCT, all of these have very small acquisition times, and one can get the epithelial maps in addition to the other information. So these, for example, are the two maps from the Cassia 2 and the Vivo NX from Optopol, where you get the pachymetry, topography, and the epithelial mapping. The epithelial mapping is given in different zones. Mostly for all machines, it's the central 2 mm zone, and then for different machines, it may go up to 7 millimeters or up to 10 millimeters. And for each zone, one may get the average, the maximum, and the minimum epithelial thickness. Now, before we go on to understanding this implication of refractive outcomes, it's important to know what is the normal distribution of the epithelium. So, variable epithelial thickness over different corneal zones is the norm. And epithelium is thickest at the center, it's thinnest superiorly and temporally, which is partially due to the action of the blinking iris also. And this is in contrast to the pachymetry, where the corneal thickness is thinner inferiorly. And we've seen that in the North Indian population, the mean central epithelial thickness is on the higher side of what is reported in normal. We found that the mean thickness was around 60 microns, as compared to literature where it's ranged from 48 to 59 microns. And sometimes when we want to plan refractive surgery, it's good to know what our population has. Now, the other thing which we often don't realize is that the epithelial stromal interface forms a significant refracting interface in the cornea. And that's because the refractive index of the epithelium is higher than the stroma. And the central epithelium contributes to approximately 1.4 diopters of refractive power in addition to the refractive power of the cornea. And despite being a highly active self-renewing layer with a complete turnover in 5 to 7 days, under physiological conditions, a constant thickness profile is maintained so that a stable corneal power and ocular diffraction is maintained. But it's also important to realize that the epithelium is not a passive bystander. It's a dynamic entity which responds to the underlying imperfections of the underlying cornea. So the epithelium tends to thin out over the hills and thicken over the valleys. Just one of the extreme cases, we talk often of confocal keratoconus, but just as a representation to understand the concept. So this is a 24-year-old female with keratoconus in the left eye. We can see the cone in the left eye, and as can be seen in the image extremely or to the extreme right, shown in the blue, the epithelium is thinned out, shown in that blue area, and that's because the epithelium has thinned over the hill, that is the cone. The rate of change of curvature is important. The rate of the curvature in the cornea changes post-ectasia, whether it be iatrogenic or it be natural ectasia like keratoconus. And what we are concerned about here is the change in curvature that we induce post-refractive surgery, whether it be a myopic refractive surgery or a hyperopic refractive surgery. There are certain rules to the epithelium which it tends to follow. So there's the proportional change. It changes in proportion to the amount of ablation. The higher the amount of ablated stroma, greater is the epithelial thickening. The more abrupt the change of curvature, greater is the epithelial thickening. And this is significant where we have smaller ablation zones. So if we have smaller ablation zones, the rate of change is more, and the epithelium tends to thicken more, and so we have more regression of the refractive effect. But also it's important to understand that the response is not entirely linear. So we don't have a linear response if we treat 2 diopters vis-a-vis 10 diopters. The response is more for the smaller diopters, and then it tends to flatten out because there are biological constraints to the response of the epithelium. What's been seen mostly is because in myopic corrections we tend to flatten the central cornea, so the epithelium tends to become thicker in the center, and it tends to act as a plus lens, and that's what can lead to the regression if it goes beyond a certain physiological limit. Similarly, in hyperopic corrections, the central cornea is steepened after surgery, so the epithelium tends to become thicker in the mid-periphery and thinner in the center. And thus, in myopic LASIK, it acts as a plus lens, and in hyperopic LASIK, it acts as a minus lens and tends to lead to regression. It's been seen that around a 10 micron increase in epithelial thickness is associated with up to 1 diopter of myopic regression. And more importantly, the stabilization of the epithelial modulation may take up to 3 to 6 months after LASIK, and even as long as 2 to 3 years after PRP. it's important to study the epithelium whenever we are looking at regressions or treating a patient, retreating a patient, because not always in myopes also you have a central thickening. Sometimes the epithelium may thicken similar to a hypermetropic correction, and then instead of regression and undercorrection may be seen. So it's important to evaluate the patient in every case. So coming to the practical uses, where do we use it in our clinical practice? So one is determining eligibility for keratorefractive surgery and the choice of surgery. For example, in this article published by Roots et al. In AGO 2020, they studied the epithelial relation to the steepening, and they realized, they studied 100 patients, and these are classic examples. So the exact picture on the left, if you see a steepening on topography and it's associated with a focally thin epithelium, it means there could be an underlying form of keratoconus or ectasia because the cornea is steepening there and the epithelium over that is thinning. So that rules out or goes against performing a laser vision correction. On the other hand, if we see a steepening with epithelial hypertrophy, for example, in that yellow area seen at the bottom in the image on the left, that is a picture which we often see with contact lens warpage. So one would see steepening on keratometry, topography, but if it's associated with a corneal thickening and epithelial thickening, then it implies that there is no underlying ectasia and one could go ahead with the laser vision correction. So in the findings of this study, they evaluated that after incorporating epithelial mapping into evaluation, the eligibility of the patients changed in 16%. So 10% initially considered unfit were now considered suitable for refractive surgery, and 6% initially deemed eligible were screened out. Also, apart from saying whether the patient can go ahead with refractive surgery or not, the surgery of choice changed for 16% patients. So 11% patients originally deemed poor candidates for LASIK were considered eligible. So these would be situations where you have a steep keratometry and one thought that one would want to go ahead with the LASIK and one might go ahead with the PRK because that has lesser chance of ectasia. But after studying the epithelial pattern, it was determined that these were all right for undergoing a flat-based procedure, whereas 8% patients lost eligibility for LASIK and it was decided that no, they may be suitable for a surface ablation. So that's one use. The second is predicting or ruling out development of future ectasia. For example, this is one of our patients. He's a 22-year-old male and he wanted to join the army and requested refractive surgery. Now a very small refractive error, K-max is within the normal limits 46.3, but the pachymetry is 448 microns. Our concerns with these patients are, one, we want to rule out whether there is ectasia, do we need to follow up these patients frequently, and secondly, tell them whether they can go in for some form of surgery or not. And obviously, as we look at the Bellin-Ambrosio map, the maps are normal. The D is a little yellow because the cornea is too thin because of that one parameter. So one knows that there is not likely to be any abnormality. And this I'd like to highlight that tomography and topography, if evaluated carefully, give us the answer in most of the situations, but the epithelial mapping just it helps to add on and reinforce our findings in most of the cases. So in this case, you go into an epithelial mapping as there are no hills and no valleys, what is suggested on tomography. So the normal pattern of epithelial distribution is followed, that there is a thinner epithelium superiorly and thicker in the center and inferior. So what can we tell such patients? That you are not a candidate for keratorefractive surgery at least because of inadequate corneal thickness, but you are very unlikely to develop ectasia in the future, and so we don't want to follow you up very frequently because that itself is an also important concern. The patient is concerned that I have keratoconus or not. Then the third is customizing enhancements for regression. So there are multiple culprits for regression. Stromal remodeling, development of ectasia, naturally increasing the axial length of the eyeball, development of cataract, these are all what we know of. Epithelial remodeling is something that we are now becoming gradually aware of. So for example, if you have a patient with regression after LASIK and we plan this for enhancement, the amount of epithelial hyperplasia should be checked. If the hyperplasia is not significant, it means that the epithelium is not contributing significantly to regression of the refractive error. And then one could either do a PRK or a flat lift and ablation, and both would work well. On the other hand, if one has a significant central epithelial hyperplasia present, that means that the epithelium may be contributing significantly to the regression. So if let's say you have a minus 1.5 of regression, some part of that is contributed by the epithelium, and you do a PRK, you remove the epithelium and you ablate 1.5 for 1.5. The patient would end up having a post-operative hyperopic surprise. So in these situations, either you undercorrect what you had wanted to do for the PRK, or one may prefer that you lift the flap and do excimer rather than doing a surface ablation. So in that sense, it helps to refine our outcomes. Another clinical scenario, again one of our patients, so this was a 28-year-old lady. She underwent PRK 9 months ago for around 3.5. She had plano refraction 6.6, both eyes till post-op 6 months. Then she came with a slight blurring of vision, and there was a refractive error of 0.5. And this would fall in the category of a regression, and this is more after 3 months after surgery. And so if we look at the pre and the post-op maps and the difference map on the right, so this is a fairly well-centered ablation. But if you look at the epithelial mapping, so the epithelium is thickened in the center. The steep axis on the keratometry is at 85 degrees, and if we see the epithelium is almost also at steeper in that axis. So the epithelial hyperplasia probably may be contributing to the effect of the regression, and in these cases it's been shown that in the early cases, if we start steroids, they may have an effect before we go in for a re-enhancement. So in this patient, we offered her topical steroids. She just came recently. So topical steroids were started, and after steroid treatment, the epithelial thickness has been shown to regress, and so one can watch these patients. If it regresses, fine. If it doesn't, then one can go in for a surgical re-enhancement. And the last part is planning therapeutic treatments for irregular corneas. So for example, this was a 30-year-old lady. She was diagnosed as keratoconus, advised bilateral CXL elsewhere, and she came to us for a second opinion. Best corrected visual acuity was 612 and 618, and the maximum keratometry was greater than 48 diameters in the right and 47.8 in the left. So for those who are familiar with tomography maps, one would understand that one needs to look at variable factors, but a lot of people now are looking at tomography who may not be cornea surgeons per se. And so probably this is the reason that led the patient to being diagnosed as keratoconus. So she had what appeared to be a thick cornea centrally. One can have keratoconus even with thick corneas. And there was an anterior and a posterior elevation on the pentagram. And the pentagram classifies it as a stage 1 keratoconus, and which is why probably she was diagnosed as having keratoconus. But the epithelium over the cone, if you go to the epithelial mapping, is much thicker, contrary to what one would expect. If there were a cone, the epithelium would be thinner. So here the epithelium in the center was much thicker. And so if you look at the patient again on slit lamp, there was this irregular heaped up epithelium which was seen on retroillumination. And this was a case of pseudokeratoconus due to epithelial basement membrane dystrophy. And it's been shown that EBMD is one of the most common causes of misdiagnosis of cases being diagnosed as ectasia, whereas it's actually a pseudoectasia. She had a similar picture in the left eye and was more symptomatic in the left eye because of the recurrent erosions. And the central epithelial thickness was 80 microns. So we went ahead with removal of the epithelium using the PTK mode. So 80 micron depth was removed over the central 6-7. We could have gone ahead with a PRK as well, but the patient wasn't interested in refractive correction, and she just said that, I just want to get rid of my symptoms of recurrent corneal erosion and pain. And one can see on the image on the right, the difference map that it's showing the pattern of ablation is very similar to what I showed for the irregular epithelium. So this is immediately after the PTK was done. So this is the epithelium, and the pattern is very similar to that. And so this is after 6 weeks of PTK. There was a central flattening of around 3 diopters, despite no refractive error having been fed in. And the CDK improved by 2 lines from 618 to 69. The patient's symptoms of the rectal erosions and pains resolved, and the patient was happy. So we need to understand that the epithelial irregularities clinically and you see on epithelial mapping can be picked up, and then we see. So in conclusion, how is epithelial mapping changing practice patterns? The first one of the things which I haven't mentioned here is the transepithelial PRK, which is being done now with the streamlight and all. So all patients who are planned for a transepithelial PRK, one must look at their epithelial profile, because if an irregular epithelium is there, then removal, trans PRK may not be the best thing, and mechanical removal may be advisable. screening candidates for refractive surgery, that is ruling out those with early keratoconus and ruling with those with apparent steepening due to some other cause. Determining the choice of refractive surgery, whether one wants to go in for a flat CAD-based procedure vis-a-vis a surface ablation. Predicting or ruling out development of future ectasia in patients with either very thin, very steep, and usually these will be seen in combination corneas. Customizing treatment of regressions, whether you want to relift the flap, whether you want to do a surface ablation procedure. Refining treatments of irregular corneas based on the epithelial profile. And the last is the AI for detection of forms of keratoconus. So at least in my experience, I found that if you can read a tomography scan well, we are able to pick up even forms of keratoconus very well. And just, at least I have not come across any patient where the epithelium was thin and the patient had a keratoconus. That we're usually able to pick up on tomography. But there are enough studies and more to show that the epithelial pattern over the entire cornea is altered in cases which are likely to develop into ectasia. So if epithelial maps are integrated in by deep learning or AI for detection of forms of keratoconus, these can be incorporated along with the topography, pachymetry, biomechanics and elevation maps, and that would help increase the sensitivity of cases which are obviously very apparently normal even on tomography or topography, but despite that, these are some of the cases which want to develop ectasia in the future. So there is the utility of epithelial mapping. Thank you very much.
Thank you, ma'am. That yesterday also we had a small discussion. I also shared some cases, and I just want to ask you. You said that you do PTA for EBMD cases. Doesn't it tend to recur, or like do you do it routinely?
So usually if one is